Well, good morning, everyone. Good morning, and welcome to St. Bart's in Midtown Manhattan. My name is Meredith Ward, and I serve as the Associate Rector for Pastoral Care here. And on behalf of all of us, it is my joy and delight to welcome you to this Sunday morning forum where we have sacred conversations about the things that matter. Whether you're here in the room or joining us online, you're very welcome, and we're glad you're here. This morning, we are beginning a three-part series at the Forum, led by my colleague, the Reverend Molly O'Neill Frank, on what healing looks like, conversations on suffering, death, and medical care. And this morning, for our first session on this topic, we're joined by Liz Blackler, Program Manager for the Ethics Committee at Memorial Sloan Kettering. And without further ado, Molly, I'm going to turn it over to you.
Thank you. Thank you so much, Meredith. This is just obviously a subject that I think most parishioners now know is near and dear to my heart. It is where I'm a bivocational priest. Half of my time, more than half of my time, is spent at MSK, and one of the nicest things that has happened to me at MSK is being able to work on the ethics committee with Liz and to be able to get to know a little bit more about how people are working in an ethical framework at the end of their lives in a place like Memorial. And it's just a great honor to have had Liz be able to come and speak to us today. She is widely published and widely traveled and goes to many conferences and speaks about ethics, which is really sort of top of mind at this point in the 21st century for so many reasons that we'll explore. So without delay, Liz, we have a little brief sort of bio of you as starting as a social worker, but maybe tell us a little bit how you got involved with ethics at MSK.
Sure, thanks Molly, and it's a delight to be here, so I'm very excited. So bioethics, I suppose for me, is a second career. So the first 15 years I did anticipatory end-of-life therapy as a social worker, both at Columbia Presbyterian, Calvary Hospital, and then also at Memorial Sloan Kettering. And as with many ethicists, it was a series of patient cases, situations that I confronted as a social worker that made me ask more questions and realize that there were more questions than answers. And over, I would say the course of 10 years, I went back to school, got a master's in bioethics, started doing ethics consultations at the hospital, and then now I run the ethics consultation service full-time. But for me, it was one patient whose wishes we were not supporting in the hospital setting. So he was at end of life and was requesting to withdraw his ventilator, and his surgeon, his oncologist, and his family would not let him do that. And so as a social worker, really grounded in this idea of autonomy, not understanding why it was not permissible to allow him to decline or to withdraw treatment. And so this was many years ago, this case, that made me just start thinking about it. It ended up getting me into ethics full time.
And so maybe talk a little bit about the field itself. One of the things that we're going to be doing for the next 2 Sundays after this one is exploring the world of the intersection of spirituality and chaplaincy and end of life, but it definitely intersects with ethics as well. There is nothing, those of us who are in the world of ministry are often dealing with ethical issues, and chaplains are certainly sort of confronting those issues as well. Maybe tell us a little bit about the history of biomedical ethics and how it plays out now.
Sure. So bioethics is an academic sort of field, if you will, that has grown out of atrocities that happened in World War II. It also has grown out of this technology and how medical technology has improved in such a way that we have the ability to sustain life for longer. And so I would say the bioethics is the 20,000-foot view of what's happening at bedside. And so we start with the Hippocratic Oath, this idea of do no harm. And so the Hippocratic Oath for many, many years was enough that allowed clinicians to help make recommendations and decisions with the idea of wanting to do best by a patient. I think as technology has shifted and changed, there are more questions about how and when to use such technology and how to sort of the discrepancies in the moral discernment that comes from having lots of options and figuring out how to best apply it at the bedside. So bioethics I think of is like the academic piece of it. It's a 20,000-foot view. Out of bioethics came clinical ethics consultation. That's really the zoomed in at bedside. How do we apply the moral reasoning, the philosophy of bioethics at the bedside? Most hospitals, anybody who's accredited by the Joint Commission and who receives Medicare and Medicaid funding, which is all hospitals, are required to have access to an ethics committee that can help assess and offer support and guidance to patients, caregivers, and clinicians to help make these decisions and make recommendations that are in the best interest of patients. And so I think of clinical ethics as this bedside. How do we apply this reasoning to patients and caregivers in real time? And that's where I live in, is this area of just trying to help clinicians reason through really difficult situations.
So maybe you could talk a little bit about sort of the classic model of medical ethical framework and maybe how that's applied and then how it's maybe shifted in the 21st. I know that there are more contemporary, sort of like the Kubler-Ross idea of how we deal with grief. I mean, we've now moved, I think, a little bit beyond that, or some people have, in terms of how they look at bereavement and grief. But maybe the 4 quadrants of the classic medical ethics framework, and then.
Sure. So Beechamp and Childress wrote a resounding book, a sentinel book called The Principles of Biomedical Ethics, where they talk about the 4 cornerstones of medical ethics. The first is autonomy, so this idea of self-determination. I sort of referenced that earlier with this case, that patients ought to make decisions that are aligned with their personal beliefs and values. In order to do that, you've got to have informed consent, which means that patients have the right to have all the information they need to make decisions aligned with their beliefs and values. The second quadrant or cornerstone, I would say, would be beneficence, this idea of best interest. So clinicians have this obligation, this ethical and moral responsibility to make medical recommendations that are in the best interest of a patient, beneficence. The third quadrant, I already mentioned as well, is this idea of non-maleficence, do no harm, right? So this is the Hippocratic Oath. Everything that we are recommending, the risks the benefits should outweigh the risks. So this idea that we ought not to do something that causes harm unless there is an equal benefit that comes with it. We'll talk a little bit about that. In cancer, there's a gray area, and it's really it's complicated sometimes to assess the best interest, or do no harm, and we'll talk about that in a minute. The fourth cornerstone is justice. So this idea of equity and equality for all, access to health care. In COVID, we talked a lot about allocation of resources, allocation of scarce resources. So those are the 4 cornerstones. And I think that that's the foundation. So when I'm teaching and training my new ethics consultants, we talk about these foundations and ethics, and then we build on it from there. So I often talk about how there's tensions between things like autonomy, right, self-determination, and best interest. So what I want is what I want, and yet is it in my best interest? And so those tensions come up in healthcare all the time. From there, we'll use non-maleficence, this idea of do no harm. In medical ethics, we talk about the principle of proportionality. So out of these 4 cornerstones have come a whole lot of other terms that we sort of think about when we assess and do moral reasoning. So the principle of proportionality is this risk-benefit analysis. So when I'm meeting with clinicians and with families, and families are requesting a 6th-line chemotherapy, let's say, that has a low chance of working and a high chance of causing harm, physical harm, the question is, ought we do that? Is it in the patient's best interest? Should we do something Can we offer something that causes harm without benefit? What's the efficacy of things? And so that's how we use the cornerstones to sort of dig in and think about principle proportionality. With that said, we often have treatments that may not have efficacy, but they may also not cause harm. And so if you can rationalize, reason that maybe it's okay, it's ethically permissible to proceed with an intervention if the benefit, there is moderate to low benefit and there's moderate to low harm. And sometimes we will help guide and support clinicians in making those, in supporting those requests from families, because we know that there's an emotional piece of this, of wanting to try something. And if it's not causing harm, then we can sometimes rationalize it.
That's great. That's really great. Maybe you can reflect a little bit on how this issue of autonomy has shifted really in the last, say, 25 years. You know, my sense of things, I think, is that, you know, there was a certain amount of like, I'm going to do whatever the doctor tells me to do. The doctor's right. The doctor knows. And I think, you know, we have some shifting there. So.
Sure. You know, so medical ethics, bioethics is not just about experimentation in World War II. It's also about things like, it grew out of the civil rights movement, right? So this idea of autonomy and patients having the right to ask questions and be a part of their medical care. But we didn't start that way. 75 years ago, the oncologists were outside of a room in a hallway whispering to family that their loved one had cancer. And decisions were made not to share information about diagnoses or prognoses with people. And that pendulum of paternalism, right, sort of physicians know best, physicians are making medical recommendations based on, you know, their medical degrees and their years of experience, in theory, in the best interest of a patient, without talking with the patient about what those options were, without obtaining consent, informed consent. The pendulum has swung all the way to shared decision-making, patient-centered care, and this idea that patients now and family members ought to be a part of this discussion. It's understanding why certain recommendations are being made. Patients want to be a part of that. I mean, sometimes it's Dr. Google, right? So patients come in with a lot of information, sometimes very good information about the treatment options, about prognosis, and wanting to actively participate. So we've swung all the way to this place where patients are at the forefront and very much participating as much as they want to in decision making. I think a lot of the work that my team and I do is mediating discrepancies and differences of opinions between clinicians and patients and families about what ought to be done. So we've swung from this place of whispering outside of the room all the way to now having to justify and sort of explain to patients why certain treatments can be happen and cannot happen. So we've sort of swung all the way.
Yeah, that's great. I mean, I think looking at what you were talking about cancer care being a particularly interesting area for an ethicist to function in because of these continually emerging therapeutics. And I think maybe you can speak a little bit to the kinds of consultations, an example of a consultation that your team gets, and maybe also how like the sort of nuts and bolts of how you do that consultation. You get a phone call, who is it from, why, and what do you expect to have happen?
Sure. So we do about 150 ethics consultations a year. I would say half of them come from physicians and half of them come from advanced practice providers, so nurse practitioners, physician assistants, and nurses.
Liz, I'm going to interrupt you for 1 second. I will say that part of what I think Liz and her team have done is also
Stigmatized.
Thank you. Destigmatize the need for an ethics consultation. So the ethics committee functions really in a very Swiss sort of way, and you know it's fine for a patient, for a nurse, for a doctor. It's just another data point.
Yeah, so we worked hard to get to this place. When I first took over the ethics consultation service and started co-chairing the ethics committee, a majority of the consults came from physicians. There was a spattering of requests from nurses, but not much. We spent the first couple of years raising awareness to ethics consultation and not only destigmatizing it, but making it very clear that there were no repercussions for calling an ethics consult. So anybody can call one. Now we get more consults from their nurses and advanced practice providers than we do from physicians, right? And so we worked hard, and I actually think our nurses at bedside have a different perspective and often have questions and concerns that are quite ethical that we can address. We get about 3 to 5 ethics consults a year from patients or families. And one of our missions these last few years is to raise awareness to patients and families about ethics consultation. It's a hard sell because we have to teach patients and families about what clinical ethics consultation is and how some of the issues, the frustrations that they have may be ethical. So we're working on that. So we'd like there to be more ethics consultations from patients and families. When we get a consult, most of them come through an electronic order, so we've got an order system. We also have anonymous consultations that come in. And our ethics consultants, we are trained to first recognize our own bias, right? We all have an idea of what we might want to do for ourselves and our families, and then set it aside. We are in many ways Switzerland. This idea of there's often more than one way to go about something. And so my team's job is to make sure that everybody has a voice at the table and that the most vulnerable person has the largest voice. And so that we have a good understanding of what everybody's perspective is and then try to mediate it. So we will sit at a table and we will mediate and try to come up with some sort of principled resolution, something that can be supported by all. That's for some of the cases. Some of the other cases, the other thing with ethics to know is that we are also grounded in law. So there are certain laws at play, and we are often the tour guide, if you will, through these laws, helping to explain to patients, families, and caregivers why certain things happen a certain way. So there are some sentinel laws out there about decision-making. And so I can talk a little bit about,
Please, yeah.
So some of the cases, consults that come up, and I think when I was prepping for this, I wanted to talk a little bit about this, is that sometimes we will have a patient in the hospital who has lost decisional capacity. So they are unable to participate in their medical care. They can't communicate with us in a way that's meets the criteria for capacity. And so there are laws in place that help us identify who is going to speak on behalf of this patient. And so the Congress passed the Patient Self-Determination Act in 1990. What that act does, and it lets patients have a previously expressed wish. It lets people fill out a healthcare proxy. This is a form that lets somebody identify anybody else in their world to make medical decisions on their behalf, so they can give their decision making to somebody else when they lose capacity. The other thing it does is it allows people to complete living wills, detailed, forms about what, if this happens, I don't want this. If this happens, I want this. It sort of solidifies this idea of a clear and convincing evidence that the patient who cannot speak to us today has already made decisions about how they want their medical care. That's important. Unfortunately, nationwide, about 25 to 30% of people complete healthcare proxies. Most people don't, for lots of reasons. I think it's hard to think about a day when you can't make your own medical decisions or any decision. It's hard to wrap your head around that. So most people do not fill out healthcare proxies. So what happens is that the hospitals are left to help identify someone on their behalf. New York State Family Healthcare Decision Act of 2010 gave hospitals the authority to identify a surrogate decision maker for somebody. So if you lose capacity and you don't have a healthcare proxy and you are married, then your spouse is the person that makes decisions for you. For many people, that's fine, right? For some, if you're not married, then it goes to your adult children to make medical decisions. But it's not just the oldest or the one that's at bedside, it's all of your children together must make decisions, and they must agree. So you can imagine, right? You can imagine what happens. My team gets consulted because you have a patient without capacity with an advanced cancer whose 6 children, and this happens all the time, are at various levels of understanding what's happening and all wanting something different. My team has to come in and help mediate and help try to get everybody to agree on all the big decisions. What do you think we do if they don't, if all the surrogates of equal standing don't agree? We are told to err on the side of life. That is what the law says. That's what our legal team wants. It's, there's a little bit of a risk involved with that. But we are trying to get children, adult children, who have different opinions about what's happening to agree on how to best take care of mom. These consults come up all the time. So there's a piece of the law. I'm coming in and saying, Family Health Care Decision Act says all 6 children, even the one that lives in Japan, has to all agree on everything, or defer, abdicate their role. And then my team works on mediating with them to try to come up with a plan. Sometimes we're able to do that, and sometimes it's complicated. Family dynamics are complicated, right?
No, they're not.
Yeah.
I want to be sure that we have some time for questions. I'm not being a timekeeper. I don't have a watch on today. But I want to dive in a little bit more into this idea of proportionality. Because I think, one of the things that we see at MSK is, it's a research hospital. It's a wonderful hospital. It has, there is something up the sleeve of a doctor, by and large, a lot. And sometimes, the question of proportionality of care is very lively. Could you talk a little bit about how you work with that with your team?
Yeah. So,
Maybe with an example. Yeah.
MSK is filled with really smart and dedicated doctors who have a wealth of information and experience. And I think we talked about this pendulum swinging from paternalism to this idea of patient autonomy and participating. I'm often involved with cases where there are false choices. So where a clinician, a scientist, will look at a situation and will say, well, we could do this and we could do this. We ought to, examples would be, do we dialyze at end of life with hopes of improving kidney function, with hopes of improving capacity, with hopes of getting someone to a little bit more chemotherapy, right? Do we intubate someone, mechanical ventilation on someone to wait for impact testing to come back to see whether there's a mutation that we can treat with an immunotherapy? And when I'm fine, sometimes we're involved because families are being given this sort of menu of options. And my job is to remind clinicians that part of their role, their responsibility is to help identify what's in the best interest, what is the right recommendation for this, and instead of just offering all of the options, to sort of think about how do we align wishes and values of a patient, what's important to them, with medical recommendations that can help achieve those goals. And I think it's, I'm sort of talking vaguely, right? But I think it's really hard. We get stuck in this place where we can make recommendations based on numbers, based on lab work, and not based on what's happening in the room at bedside. And so when I'm working with new consultants, part of what I'm always saying is you have to actually go and see the patient. You have to stand in front of them. You have to talk to all of the people that are taking care of these patients to understand what's happening, the full picture, and not a narrow view of what's going on. There's always more that can be done. I mean, modern technology, we have made such strides in the last 50 years. We can prolong life inevitably, not inevitably, but almost. And so, in my world, in cancer, in the setting of cancer that cannot be treated, the question is, is it the right thing to do? And it's different for every person. But what does it look like to have mechanical ventilation for the rest of your life? Where do you live? Let's zoom out a little bit and think about what a plan looks like for a patient. And are we really, truly talking with families about what it looks like for this patient in a compassionate way? Yeah.
That's just so well put. I mean, I think, and I've seen it in my work there, we all are bringing in ourselves into the room, and to try to sort of be a third eye on yourself and to make sure that you are taking into account all the factors. Doctors do too. They come in, and it's really hard when somebody is a patient, especially some of our younger patients, and their families are asking for anything, for them not to offer, even if they know that it's probably maybe not going to be the most beneficial thing or effective thing. Having a menu of options. There is a term of art. I can't remember what it is. That to not necessarily offering something is very hard for a patient to say, oh, I don't want that. If they really if they do, it's very, very tough. How do you? I don't know how we're on time. I have two big questions I want to ask you, but I also want to have an opportunity for the audience and for those online. Meredith has got a secret line into the online folks, and so come up with some questions. But while you are coming up with a few questions,
let me just interrupt you one sec. For if you're here in the room, we do have plenty of time for questions. Natalie Johnson has question cards that just raise your hand and she'll bring one to you. If you're joining us online, you can put your questions in the chat or in the comments section, or you can email me directly at mward@stbarts.org. And we'll bring those questions to Liz.
Great. So are there types of ethical consults that are more difficult than others? Are there ones that you sort of have a kind of clear runway with, and there's ones that are really tough? Can you speak to some of those?
Sure. We recently had a case of a young adult in her mid-20s who requested an ethics consult. I'll just say she had a lymphoma that was on third-line treatment. And the drug that the chemotherapy that her oncologist wanted to start next there was a shortage. And so we have a pharmacy, director of pharmacy who works with oncologists to identify a plan of action when there are drugs that are on shortage. This is happening more and more, I would say, not only with things like narcotics, but with chemotherapies. And the decision was made in the C-suite, right, with clinicians, that this specific drug, I'm forgetting the name, would just be used for leukemia patients. First line for leukemia, because the efficacy was higher, right? So we had a better chance of having a better efficacy with someone with a leukemia. And I'm generalizing, I'm not going to get into the science of it. This patient in her 20s had done all of her research, and her doctor had said to her, I'd like to start you on this drug, but I can't because I'm being told that I can't use it because it's, we're under a severe shortage, and it's being held for patients who have a different diagnosis because we have more data that it works, there's more efficacy on it. This patient came to us and pled her case in a very articulate and thoughtful way, not understanding why this drug, this is her drug, she should get it, it could work for her, it's going to, the drug she's on currently has side effects that are unbearable for her, she's going to die, she needs to get this drug. She's that thing that, so you have, an allocation of scarce resource policy, The reason we have policies is so that we're not making one-off decisions that can be, have bias in them, right? We liked this young woman. She was thoughtful, smart. She was pleading her case. You can't make a decision about an allocation of a resource in the setting of one person. You have to zoom out and have medical criteria so that we're not being biased, right? And so we do the same thing with ventilators during COVID. But what was so hard about this case is that she wasn't wrong. Like, she pled a good case. She's on all of the blogs and the online forums for people with her cancer that are saying, we have leukemia patients in there saying, I'll give you my drug, you can have it. She's like, I found someone in a waiting room who's on the drug, who's willing to give it to me. And so, and when you zoom in, it's heart-wrenching because she's made a good case, and yet there is a reason why we have these policies. The thing about ethics that I failed to mention is that we make recommendations. We do not go in, we do not have the authority, nor do you want the authority to tell people what to do, right? We make recommendations unless it's based in law. There are certain ethical conundrums that come up where our recommendations are binding. But most of them, we're an advisory board. With that said, because we are we have earned our stripes, if you will, at the institution, I can't think of a case where our recommendations were not followed, right? But they don't have to be. But with this young woman, it was messy. We couldn't tie it up into a bow because at the end of the day, we couldn't give her the drug. But there's more to this, right? Because this oncologist, you mentioned earlier, most clinicians really have this heartfelt wanting to do best for their patients. This clinician felt, despite not having the data to back it up, that this drug was the right drug to do next, and she shared that with the patient. So, so a piece of ethics is always trying to come to some resolution, and sort of this doctor was uncomfortable with the policy and shared that with the patient, who then really felt like she was going to die without this drug. And so there's a lot of work that happens behind the scenes with the oncologist to help and get her to the right people to talk about the clinical decision about the policy, so that she can sort of, at least has to be an emissary of it, if you will. But I will, and the other piece of this case is this young woman was blogging about how MSK was not giving her the drug that she needed, and and so it was a heartfelt case for me.
So you're getting a little bit of a sense of, it's not so easy, it's not so clean, it's not so clear. These are some great questions. Here is one. To what degree do doctors still consider the death of a patient a failure? What personal characteristics in a doctor affect how they think of this? So basically, again, continuing with this idea.
Yeah. I mean, I think most doctors, if not all, take every single one of these failures personally. I think it's terminology too. It's what I like to say is that despite our best efforts, we don't have the answer for what's happening medically. We can't fix everything. Most, and certainly, our clinicians get to know these patients and very much want to do right by them. And instead of zooming out and thinking about a larger, how do we take care of patients, they're fighting for their patient, advocating for their patient individually. So I think that's important. There's a lot of studies that show that oncologists that look like their patients are more likely to have a harder time acknowledging their finding peace with the failures, right? And so we also know instinctively and in the literature that female physicians are more likely have a burnout quicker and have a harder time because really wanting to do right by each patient. But I think most of our clinicians feel this way and feel this failure. I don't love the fight terminology in cancer personally, so it's not that the patient failed this drug, it's that we don't have an answer. We don't have the right technology, the right drugs.
And Liz, I think we can sort of mostly say that when I saw someone say failure, like as if death is a failure, of course not. I think at a place like MSK, I think if I may, what you may be talking about are some of the patients who are who are young and who have run out of. Death, of course, is not a failure. Death is inevitable. We know that, and we will be continuing to explore that in different modalities. But in terms of a medical intervention that has been offered, and as you know, a place like MD Anderson or Dana-Farber or MSK, people do come there for success. It's part of how the hospital is messaging, and it's part of the excellent research that we have there. So I think that's probably what the failure.
I mean, we have a self-selecting group of patients and families that come to MSK hoping for prolonged life, hoping that to defy odds. We let me be clear, I work in crisis, so I don't see the 20,000 patients who went through treatment and are now back living their life. I see the ones that are struggling in the ICU, who are struggling to balance. And I think if I had a dream, and I was talking with Meredith about this idea of, how do we balance hope with an understanding of what's happening medically? And so I can think of meeting with many patients, but one gentleman who was 87 with stage 4 non-small cell lung cancer, widely metastatic, no cure for that, who couldn't fathom the idea of death. It had never crossed his mind that he was going to die, had made no plans, had not been able to talk to family. That is a phenomenon that I see a lot, right? This idea that we are immortal. And so, death is not a failure. Death happens to all of us. It's the path in which we take to get there that I'm very passionate about. So I believe strongly in this idea of acknowledging, of having balance of both hope with this understanding of what's happening. And it's not just patients and families. Our clinicians, my clinicians, have an obligation to talk with patients and families about prognosis early and often so that it demystifies it, because we can balance hope. This is what we're doing now to give you as much good time as we can, and yet there may come a point later where I don't have any more tricks and tools in my toolbox, and then we're gonna have to have a different kind of conversation. And so that's my passion, and I meet with people who have not had these conversations, who were not ready for those conversations.
Yeah. Does the patient sit with you in the ethics consult?
Many times, yes. So every consult's a little different, but I like to meet with patients and families and get their perspective, right? And so sometimes the best case scenario is I like to meet with everybody individually, right? So I meet with a team, I get their perspective. I like to sit at bedside and talk with patients and their family, their caregivers, their family members, and get a full perspective. And then I bring everybody together. We often do these big meetings at bedside, right? If a patient can't travel to a conference room, we're in the room and we're having a conversation. A good ethics mediation, I think the mediator, my job is to have a sense of what everybody's thinking. And then I try to help make sure everybody has a voice and gets to say what they need to say, and we come to some sort of resolution in real time. Often, though, our patients are not able to participate in some of these discussions. But for me, when you're having a meeting with family and caregiver and clinicians, it's really about, the first thing should be, tell me about mom. Who is she? What's important to her? What makes her tick? Because that's the compass. That's where we start, and we should be making recommendations aligned with this person. And that's why you need family to be there to help bring that person into the room.
Yeah. And I can say, if I may, that sometimes, amazingly for me, the compass, that person, that what makes them tick is an insistence on life and everything being done absolutely until nothing else can possibly be done. And it often, will end up in a situation that maybe, somebody, the ethics consult or the clinician could never imagine for themselves.
Well, and I think most people want their medical team to do everything they can to help give you as good of a life as you can have for as long as possible. It's what does that look like and what's realistic? What is everything? And it's different for every person. There are limits to what medicine can do. I'll also note that when a patient can't be present in a room, we go to all kinds of staff members like you, Molly, right? To find out what was it like when you spent time with mom 3 months ago for 6 visits in a row, because you have a sense and you can help bring her voice into the room. Same with our social workers, same with our psychiatrists, same with our palliative care clinicians. And so as a team, it's like, how do we, sort of make sure their voice is there? Because what they said previously is super important.
Well, to that point, does ethics only get involved at end of life? I mean, I think in inpatient at Maine perhaps, but do they get involved with other illnesses but are not necessarily end of life?
Absolutely. I mean, I think we've been talking today about end of life, but I think that from a preventative standpoint, we've been trying to raise awareness to issues earlier in the illness trajectory. So, think of research, think of genetics. We recently had a consult of a woman who has a leukemia, whose clinician wants her to get genetic testing, impact testing. And in this specific leukemia, there is a genetic piece of it that if she has, and the clinician thinks she may have it, that we would want to talk to her family. So that she could be, same thing with colon cancer, same thing with breast cancer, BRCA genes, and so we have all this technology, and and this patient's not dying, she's getting treatment, she'll be okay, and she doesn't want to do genetic testing, don't want to do it, and she doesn't want to burden her family with that, having that information, and so the clinician put a consultant questioning, struggling, because we have the technology to know more about what's happening, and this patient doesn't want it. And so, what do? I come in and I want to make sure the patient has all the information they need to make a decision that's aligned with their beliefs and values. She doesn't want to know, and she doesn't want to burden her family. Her family's anxious on it. There's reasons. My job is to support her in those reasons. Right.
Fantastic. I think Meredith has a question.
Liz, we were talking before we began about how you are having these conversations with doctors and families in a moment of crisis, and how that conversation would be different if it had happened ahead of time. I'm going to just put in a little plug here for an event we've got coming up, which the idea of which came from Molly and MSK, Death Over Dinner, which we're going to be having here at St. Bart's on Wednesday evening, October 23rd, where we begin to start to think about how do we line up these, healthcare proxies and thinking about our own end of life for ourselves. What difference does it make, or have you experienced a difference when you're encountering families or patients who have already had the conversation versus those who, and who've lined up their healthcare proxy, for example, and those who are just, deer in the headlights? I
think that there's a sense of peace. I'm going to share a personal story, actually. So as you can imagine, I, go home and visit my family and talk about my work life, and got my parents and my sister over the years to talk about their wishes and values on our own Death Over Dinner. 4 years ago, my mother was diagnosed with stage 4 non-small cell with a brain metastases the size of a golf ball in her head. She was pleasantly confused, never regained capacity, and died 3 months later, despite me having access to all the fancy treatments and the best of everything. It was a blessing, perhaps, for her, but that's a different story. My dad, who doesn't talk about anything like emotional, it was understood, the whole family understood without any question what my mother's wishes would be, and there was a sense of peace that comes with that. We knew she would want to be a do not resuscitate, that she would not want extraordinary measures, that she would want to be comfortable, that this was her priority, because we've been slowly talking about it for 10 years. The other side of that, and so that's, we did right by her, and there was no second guessing any of it. The whole family was in agreement. What I see sometimes is families who who never talked about the what ifs, what could happen. And then, families are complicated. So you have a mom or a dad who can't communicate with you. And you have all these things that were left unsaid that need to be said before so you can find some peace. And so families struggle with wanting more time because they have not been, they're not having these conversations because there's hope. And it can cause such struggle and causes complicated grief. So what we know is that years later, families are still struggling. They're still reaching out to me from my social work days, wanting to know one more time what was happening and sort of trying to find peace with it. And I think that the Death Over Dinner is fantastic. I would encourage you all to do it. I've moderated many, I've attended myself. It's a great way to desensitize these conversations and to do it in a way that could, it's thoughtful and just over time, and you form your own opinions about what you would want for yourself and then share with your loved ones. I'm a big fan. Yeah.
So Molly, I think you have one final question.
We're coming to the end. I did get a question about how one allows or plans how you will for God's miracles, and I'm going to ask that whoever asked that question come to next week. We're going to be moving into sort of chaplain-y territory with a doctor, Robert Klitzman, who's going to be, he's an ethicist himself and a psychiatrist, and has just written a book called Doctor, Will You Pray For Me, about these specific modalities, and I think it's going to be a fantastic conversation. So I would ask this person to come back. We'll talk about that. Quickly, Liz, if you had a magic wand and could change anything about the hospital system, I know it's a big one, but in just what would you do? What would be one thing?
I think it would be access. So, nothing pains me more when I meet with patients and family members who were diagnosed late, who had struggled, maybe didn't have the insurance to get to the right treatment. And so while there are many flaws in a healthcare system, if you're not being seen in a healthcare system, I think that's something that we should be able to rectify.
Access.
Access,
yes.
yeah.
Justice.
Yeah, justice.
Please join me in thanking Molly and Liz. That was fantastic. Thank you both. So as Molly said, we're going to have the second of this series next week with Robert Klitzman, who is going to be speaking more about the spiritual aspect of medical care. So I hope you'll join us next week for that. And in the meantime, please join us online for the 11 o'clock service, or if you're here, join us right next door. See you next week.